Our next section is congestive heart failure. Now, when we have a patient who in 1970, the mortality on an anterior wall myocardial infarction, the mortality on an anterior myocardial infarction was 20 to 40% of the year. That same myocardial infarction in the year 2000 was 10 to 15% of the year or less. Aspirin resulted in a 25% relative risk reduction. Thrombolytics and angioplasty resulted in a 25% relative risk reduction. Beta blockers somewhere between a 10 and 30% depending on how you look at it. So people are alive. So what has happened is that the survival from myocardial infarction has markedly improved. And what happens is that many of those people are alive and normal now, but many more of them are alive and suffering from congestive heart failure. Now, the most common reason to develop congestive heart failure after you have a normal heart is ischemia. Now, ischemia can take you from a normal heart. How do we go from a normal heart to a congestive heart failure heart? And the answer is coronary disease, ischemia, valve lesions, hypertensive cardiomyopathy. That's dilated cardiomyopathy. Let's look at our first case. We got a 62-year-old man with hypertension, high lipids, non-specific, shortness of breath, more specific. On exam now, he's got jugular venous distension, a gallop, and a displaced apical impulse. Now, the apical impulse should be in the 5th intercostal space. It should be here in the midclavicular line. Midclavicular, that's the clavicle, the middle of the clavicle, 5th intercostal space in the midclavicular line. But if you have left ventricular hypertrophy, the left ventricle, if we look at the heart, hypertrophy is out this way. And what happens is that the point of maximal impulse gets displaced. So what happens is that the point of maximal impulse shifts over because the left ventricle starts to enlarge out this way. And that is why you get an enlarged left ventricle pushing out the point of maximum impulse out to the left. So the question's here. What's the next best step in management for this guy? Well, he's short of breath. And the way to handle short of breath people at the beginning is preload reduction. Oxygen, diuretics, nitrates, and morphine. Oxygen, diuretics, nitrates, and morphine. Oxygen, diuretics, nitrates, and morphine are going to handle preload reduction. 90% of people will get better with oxygen, fluids, diuretics, and morphine. The diagnosis of this guy, S3 gallop, shortness of breath, jugular venous distension, edema, is that he has got systolic dysfunction. Systolic dysfunction and the phrase dilated cardiomyopathy can be used almost interchangeably. It can relax, but it can't contract. Systolic dysfunction is almost interchangeable with the word dilated cardiomyopathy and low ejection fraction. Dilated cardiomyopathy and low ejection fraction, almost interchangeable. Pulmonary edema. Pulmonary edema means you've got fluid bulging out of the vasculature. It's bulging out of the vasculature and into the alveoli. When the fluid is going out of the vasculature and into the alveoli, I cannot breathe. Because what's happening is if this is an artery and this is an alveolus, what's happening is we're having liquid, we're having water going out of the artery and into the alveolus, and it's filling up that alveolus filled with water. Well, how is oxygen supposed to get across that alveolar wall if the alveolus is now a little cup of soup? The alveolus is a little cup of noodles. How's oxygen supposed to get across? Well, the most common causes of pulmonary edema, well, once you have a sick, dead, leaky, weaky heart with ischemia, valvular heart disease, hypertrophic cardiomyopathies, what happens to put you into pulmonary edema? Well, what happens to put you in pulmonary edema is you get more sudden ischemia, a rhythm problem, some form of increased salt load, and that's where we have this issue here of what happens in arrhythmia, more ischemia, increase the wedge pressure. Now, normally, what is the contribution of your atrium to cardiac output? What percentage of your cardiac output is based on your atrial contribution? The answer is only about 10 or 20%. What percentage of your cardiac output is based on your atrial contribution? About 10 or 20%. Now that's if your heart is not sick and dead, leaky with valvular disease, weak with hypertrophic dilated cardiomyopathy. But if it's normal, 10 or 20% is your atrial contribution. Now, if you have a sick, leaky, dead, weak heart, you could have 40 or 50% of your cardiac output based on your atrial contribution. 40 or 50%, which as you go from sinus to AFib, poof, you lose that atrial contribution, flash pulmonary edema. You lose the atrial contribution, flash pulmonary edema. Now, what happens? Any lung disease, you get an increased respiratory rate. That's the same thing as saying shortness of breath. Well, you get a productive cough because all of this fluid in there, see all that fluid in there? You start coughing and coughing and coughing and it gets blood in it too. Why is it pink and frothy? Because it's got a little blood mixed in with liquid. Blood mixed in with liquid. It's like a strawberry smoothie. Okay? So you get cyanosis. When I'm feeling blue, all I have to do is intubate you. Then I'm not so blue. Or when you ventilate me and you oxygenate me. Well, cyanosis, of course I'm feeling blue. I'm feeling blue because I'm suffocating to death. I'm suffocating to death. Nocturnal dyspnea is because I'm lying flat and the blood is pooling in my lungs. When I'm lying flat and the blood is pooling in my lungs, then what happens is that people get paroxysmal nocturnal dyspnea. It's close to orthopnea, but it has to do with a change in position and lying flat. Now, Rales, rhonchi, and wheezing all generally mean lung sounds. It's very hard to have a precise definition of these. Crepitus or crackles, crepitus and crackles are the other breath sound. And this is a hard one, okay? It is a hard one. Now, we have recently released a new set of flashcards because this is the year that multimedia has been added to step 1, 2, and 3. Multimedia means this. Did you know that when you have to take this test, they're going to show you a person's chest, and they're going to say auscultatory point A, B, C, and D. And they're going to say, ready? You put the stethoscope at point this, and you hear this murmur. At point this, and you see this murmur. And say, which of the following is the most likely diagnosis? Or it can say, the patient comes in with the murmur of mitral regurgitation. At which point is this murmur most likely to be found? Or playing the audio tape of that murmur and actually have the image of the stethoscope moving from spot to spot. Now, we were just recently released, which say a set of flashcards on this with audio and videotapes of these things. And the issue is that Rales, rhonchi, and wheezing have almost no precise definition. That word wheezing is defined as a high-pitched sound associated with asthma. Now, I can say that, but if they play it for you, you won't know what it sounds like unless you practice listening. Well, it's a rhonchus, coarser, more gurgling, lower pitched, more like bubbling up like you were, had a straw in a soda and you blow through a straw. That's rhonchi. Crepitus, for those of you who have hair, pull the hair in between your fingers, rub your hair in your fingers, and crepitus or crackles is the high-pitched sound that you get with somebody who has a pneumonia, as the alveoli call pop open like Rice Krispies. Now this is hard. I can say this, but it's very hard to explain. So therefore, we released this year for the multimedia flashcards about the 200 physical finding questions you're most likely to see, and it has all the things that you can need about all the wheezes, the Rales, the rhonchi, all the heart sounds, neurological exams, and every form of physical exam that you could want, and probably everything you'll see on the exam and more. Now remember, as time goes on, those multimedia questions are more likely to get harder, not easier, because in the first few months after the test is released, they're testing it out. They want to see, hey, we don't want anybody to fail. Maybe we're using stuff that's too hard. 6 months and a year later, boom. We know this is what level of difficulty this is. Time to failure. time to failure. Multimedia is here. You will not only be required to know anatomically where, but they'll actually play it to you saying, we auscultated here, and we played this murmur. What is that murmur? And you'll be expected to know. Sights and Sounds of Medicine. Flashcards for USMLE by, Fisher. So on the chest x-ray, we didn't say that you should go to a chest x-ray first with a guy who's got shortness of breath like this. The chest x-ray shows congestion, but you still need to give oxygen, diuretics, fluids, and more oxygen, diuretics, nitrates, and morphine. The x-rays will find big vessels. The x-rays will show an enlarged silhouette. Silhouette is a $5 word for shadow. That's what I said here. It'll show an enlarged shadow. Why is it enlarging? The normal contour here, the left ventricular hypertrophy here. Now, curly bee lines. You notice it's curly with a K-E, not curly with a C-U, like Larry Moe N. Curly bee lines are little horizontal lines in the bases. Curly bee lines are little horizontal lines in the bases that's indicative of fluid in the interlobular septa. Fluid between lobes is called a pleural effusion. Fluid between the lobules is called curly bee lines. Fluid in the interlobular septa, curly bee lines. Effusions is fluid coming actually outside the lung, and it tends to cup up around the sides of the lung, so that basically it threads up along the side. What's the name of that sign when it comes up around the side? That's called a meniscus. That's a meniscus sign. It's forming a meniscus. That's an effusion. So what do we have? Effusion, curly bee lines, left ventricular hypertrophy, pulmonary vascular congestion. Effusion, curly bee lines, left ventricular hypertrophy, pulmonary vascular congestion. These are the x-ray findings. What should you do first? Oxygen, diuretics, nitrates, morphine. What's the most appropriate step? Oxygen, diuretics, nitrates, morphine. Should he have an x-ray done? Yes. What's the next best step? Oxygen, diuretics, nitrates, and morphine. Did you know that it's not that you haven't heard of the tests and the treatments? It's that you don't know the order in which to do them. That's the main thing that you come to learn here. The blood gas, let me guess. Guy can't breathe. Probably short of breath. Let me guess. Hypoxia? Oh, I'm shocked. Hypoxia. Yeah, I see hypoxia. And you're breathing fast? Ay, ooh, ay, ooh, ay, ay. Shortness of breath, man. Respiratory alkalosis and hypoxia. Because you're breathing fast, you get a respiratory alkalosis. Because you're breathing fast, you get a respiratory alkalosis. Why am I so concerned about that arrhythmia in the EKG? Is for two reasons on the EKG. One, what did we say the atrial contribution is normally towards cardiac output? 10 to 20%. 10 to 20%. Normally we've said the atrial contribution is 10 to 20%. But if you have a sick, dead, leaky, weaky heart, it can be 40 or 50%. Could be 40 or 50%. So we're looking for the arrhythmia, not only because it gives us the etiology, but we're looking for the arrhythmia because it's the fastest way to correct cardiac output. What is the fastest way to correct cardiac output? Fixing the arrhythmia. Fixing the arrhythmia. Well, this is a chest x-ray with fluids. You see how it's down at the bases? These white lines coming down are veins returning fluid, veins returning fluid. This is fluid. This is too much fluid. And also, the heart is increased. Normally, the heart should be less than 50% of the total transthoracic diameter. As we go from here to here, the heart should be less than 50% of the total transthoracic diameter. If it's above 50% of the transthoracic diameter, it's left ventricular hypertrophy. These infiltrates here are at the bases. Beware of the word interstitial because it really means fluids in the bases. This is an effusion. This is an effusion. See, this is fluid layering out on a person lying on their side. This is liters of fluid. Liters. How do I know it's liters? Because how much fluid? How much fluid do you even need to begin to see blunting of the diaphragms? You need somewhere between 200 to 250 milliliters to even begin to see it blunting on a PA X-ray. The lateral is more sensitive. The lateral can detect as little as 50 to 75. The lateral X-ray is more sensitive. It can detect as little as 50 to 75 milliliters of fluid. The PA is much less sensitive. To even begin to see blunting of the costophrenic angle, you need 200 to 250 milliliters to even begin to see blunting. This is a huge amount of fluid. This could be a half a gallon of fluid in there. Pleural effusion. Well, treat pulmonary edema. I have acute pulmonary edema. Oxygen, diuretics, nitrates, and morphine. Oxygen, diuretics, nitrates, and morphine. What happens if oxygen, diuretics, nitrates, and morphine does not work? The next best step is an acute inotrope, like dobutamine. Dobutamine is a positive inotrope. It increases contractility. Dobutamine also decreases afterload. Dobutamine is a positive inotrope. It increases contractility. Dobutamine decreases afterload. Dobutamine contracts the heart and decreases afterload. Dobutamine is only used acutely. Dobutamine is used acutely as a positive inotrope. Digoxin is used chronically. ACE inhibitors have very little impact acutely. ACE inhibitors and angiotensin receptor blockers are two medications that you use chronically. Sit the patient up, oxygen, fluid, diuretics, and morphine. Sit the patient up, oxygen, diuretics, fluids, and morphine. Oxygen, diuretics, fluids, and morphine. Now, you see how it says digoxin if there's atrial fibrillation? That's because digoxin does not work acutely as an inotrope. Digoxin is chronic as an inotrope. It takes weeks to months to digitalize them. But if you have AFib, it's good. ACE inhibitors decrease afterload. Let's look at our next case. 57-year-old female presents with hypertension, hyperlipidemia. Wow, this is very close, very similar. JVD, but this is an S4 gallop. An S4 gallop and non-displaced. Non-displaced. S4 gallop and non-displaced. So in this case, with an S4 gallop and a non-displaced apical impulse, they're short of breath, but they're not showing signs of left ventricular hypertrophy. That is a type of diastolic failure. Now, what is the only way to tell the difference between systolic and diastolic failure? What is the only way to be able to tell the difference between systolic and diastolic failure? The only way to be able to tell the difference between systolic and diastolic failure is to do an echocardiography. The echo tells the difference. Which of these two gets a beta blocker? They both do. They both get beta blocker and they both get diuretics. So what's the difference in the management then of systolic and diastolic dysfunction? Systolic dysfunction is much more effectively managed with ACE inhibitors. Systolic dysfunction gets digoxin, and diastolic dysfunction doesn't, because diastolic dysfunction has a normal ejection fraction. Diastolic dysfunction, I'm short of breath, but I have a hypertrophic cardiomyopathy that I can contract. So there's no point in giving a positive inotrope if I can contract. Now, what are we going to do if you're actually getting severe systolic dysfunction, congestive failure? Well, you decrease salt intake. I don't know if there's anybody who can decrease their emotional stress. But you decrease the salt intake, that's like preload reduction. A diuretic and a vasodilator. Well, remember, vasodilators mean ACE inhibitors and ARBs. Vasodilators mean ACE inhibitors and angiotensin receptor blockers. Vasodilators means an ACE inhibitor and an angiotensin receptor blocker. What is the other alternative to a person who can't tolerate or does not want to use ACE inhibitors and ARBs? What else can be used as a vasodilator? The answer is hydralazine. Hydralazine and nitrates. Now, beta blockers lower mortality in congestive failure. Beta blockers lower mortality in congestive heart failure. So beta blockers lower mortality in congestive failure because they're anti-ischemic and anti-arrhythmic. Spironolactone helps inhibit the renin-angiotensin system. Now, you notice that adding an inotrope such as digoxin is dead last. Adding an inotrope such as digoxin is dead last because it doesn't lower mortality. The most important thing about congestive failure is which medications lower mortality. ACE and ARBs are interchangeable. ACE inhibitors, the pills, ARBs, the sartans, losartan, valsartan, irbesartan, candesartan, telmisartan are interchangeable. You have a cough? Angiotensin receptor blocker. The ACE and ARBs lower mortality. The beta blockers lower mortality. Spironolactone lowers mortality. Implantable defibrillator lowers mortality. Implantable defibrillator lowers mortality in a person with systolic dysfunction, dilated cardiomyopathy. So digoxin decreases symptoms. Diuretics decrease symptoms. Remember that the spironolactone is not given in a diuretic dose. The spironolactone is given a tiny amount in order to decrease symptoms by inhibiting the renin-angiotensin system. The angiotensin receptor blocker and ACE inhibitors are generally interchangeable. Now, if you can fix a valvular lesion, shortness of breath is a reason to correct a valve lesion. What's a reason is that if you have regurgitant lesions to the point of shortness of breath, time to fix that valvular lesion. Next thing, what do you do if I have maximum medications and you're still symptomatic? Wait for a new heart on the organ transplant list. Now, the treatment with digoxin works by binding to the sodium-potassium ATPase. Digoxin and potassium are competing for the same binding site. If you have less potassium, you're going to have more digoxin around. If you have less potassium, you're going to have more digoxin around. Less potassium, more digoxin around. More potassium prevents digoxin toxicity. Now, in 1965, all we had was a diuretic, which caused hypokalemia, and digoxin, which therefore developed toxicity. Beta blockers, what is the effect of beta blocker on potassium? It increases potassium. Therefore, beta blockers inhibit digoxin toxicity. What are the effect of ACE inhibitors and ARBs on potassium? They increase potassium. Therefore, ACE and ARBs prevent digoxin toxicity. What is the effect of spironolactone on potassium levels? It increases potassium levels because it inhibits aldosterone. Aldosterone makes you retain sodium and excrete potassium. No aldosterone, you're retaining potassium. No aldosterone, you're retaining potassium. No aldosterone, you're retaining potassium. No aldosterone, and you are retaining potassium. So therefore, beta blockers, spironolactone, ACE and ARBs all increase potassium and prevent digoxin toxicity. Now, digoxin toxicity used to be a big deal. We didn't have any other drug. Now, yeah, whatever, digoxin toxicity. Digoxin toxicity. What is the most common presentation of toxicity? What is the most common presentation of dig toxicity? GI problems. Now, dig can give you CNS problems. Dig can give you visual problems. Digoxin, does it lead to hyperkalemia or hypo? Digoxin toxicity leads to hyperkalemia. Leads to hyperkalemia because it inhibits the sodium-potassium ATPase. Most common toxicity? GI. What arrhythmia? Any arrhythmia. What's the most common arrhythmia? Atrial tachycardia with block. Atrial tachycardia with block. Digoxin toxicity. What's the most common toxicity? GI, nausea, and vomiting. Gynecomastia, it's a little anti-androgenic. That's bad. Okay? But it's mild. Doesn't happen that often. Okay? Yellow halos. Why do you get that? Man, I don't know. All antiarrhythmics are pro-arrhythmic. All of them are proarrhythmic. Digoxin is just one of the many that's proarrhythmic as well. Now, if you have CNS and cardiac problems, besides stopping the drug and using an arrhythmia, we use a digoxin binding antibody. But it's only if you have the CNS and the electrocardiographic, the CNS and the EKG. You only use digoxin binding antibodies for the CNS and the EKG portion. The other things, you just wait. The other things, all you have to do is wait. Now, diastolic dysfunction means you have a normal ejection fraction. Diastolic dysfunction means you can contract fine, you just can't relax. Diastolic dysfunction, the difference in management is, if you have a normal ejection fraction, remember, systolic dysfunction is like this. Low ejection fraction. Give me digoxin. ACE. Spironolactone. But diastolic dysfunction means I contract great. Diastolic dysfunction means, I contract great, but I can't relax and open. I contract great, but I can't open. I can't relax and open. Well, diastolic dysfunction, things like hypertrophic cardiomyopathy. Diastolic dysfunction, things like hypertensive heart disease. Diastolic dysfunction, if the ejection fraction is normal, don't give digoxin. Diastolic dysfunction, if the ejection fraction is normal or high, don't give ACE or ARBs. Diastolic dysfunction, we use diuretics and beta blockers. Diuretics and beta blockers, what's the biggest difference? Diuretics and beta blockers are the #1 therapy. Now, this is the single most important thing. What makes you live longer? Yes, you know it. ACE inhibitors make you live longer. Yes, you know it. ACE inhibitors is #1. You know you want an ACE inhibitor. Go on, say it. Say it. Say, I want my ACE. I want my ACE. Say it. I want to live. Beta blockers decrease mortality and morbidity. Now, if you have a person who has a low ejection fraction, how low does the ejection fraction have to be before you withhold the beta blocker? The ejection fraction. How low does it have to be before you withhold the beta blocker? And the answer is that the lower the ejection fraction, the greater the mortality benefit. The mortality benefit or the survival benefit. In other words, if you have an ejection fraction that's normal at 50 and 60%, if you have an ejection fraction that is normal at 50 and 60%, your benefit of mortality here is less than 10%. As your ejection fraction goes to 40%, 30% ejection fraction, 20%, oh my goodness, look at that. Your mortality benefit goes 10%, 20%, 30%, 40%. Oh, look at that. As the ejection fraction drops down, your mortality benefit goes up. Who needs a vacation the most? The sickest heart. Who needs the vacation the most? Who needs the vacation the most? The vacation the most is the sickest heart. In other words, if you go from a heart rate of 100 to a heart rate of 60, if you go from a heart rate of 100 to a heart rate of 60, what increases in length? Systole or diastole? Diastole increases. Diastole increases. When do the coronary arteries fill? They fill during diastole. They fill during When do the coronary arteries fill? They fill during diastole. So, what happens here? What happens here is that when you go from a heart rate of 100 to a heart rate of 60, what happens is that diastolic filling goes up. Filling, diastolic fillings. What happens if you go from a heart rate of 100 to a heart rate of 60? As you go from a heart rate to a heart of 100 to a heart rate of 60, heart rate of 100 to a heart rate of 60, what happens is your filling goes up, your supply goes up. When is oxygen consumed? When you're contracting. So what happens as you use that beta blocker? The demand goes down, the supply goes up, you live longer. Beta blockers are antiarrhythmic and beta blockers are anti-ischemic. How do you die of congestive failure? How do you die? You die of sudden death from ischemia-mediated arrhythmia. Relax, take it easy. Fillings, nothing more than fillings. When we have time for fillings in our heart, we feel better. If there is no time for my heart to accept fillings, I feel like I'm going to die. When I take it easy, slow down, and I accept all of the fillings meant to come to me, I feel good. Fillings, good. Myocardial filling. Relax, suave, calmete su corazón, suave su corazón. Ay, despacio. And that's why when we go from a heart rate of 100 to a heart rate of 60, you live longer. And the worse the heart is, the suckier and lower the ejection fraction, the more you live. Fantastic. Fantastic. Other vasodilators? Well, isosorbide, which is a form of nitrate, is good, but it only lowers mortality when you combine it with hydralazine. Hydralazine is a vasodilator. But hydralazine could steal blood away from the heart, except you vasodilate the coronaries with isosorbide. Spironolactone decreases mortality in congestive failure because it inhibits the renin, angiotensin, aldosterone system. So therefore, spironolactone also decreases afterload. Congestive failure is the most common reason to be admitted to the hospital in the United States. People who used to die of myocardial infarctions for the last hundreds of years are now alive, but a number of them are complicated with congestive failure. People are living longer than ever. What will the boards want you to know? They want you to know that diuretics don't lower mortality, ACE, beta blocker, and spironolactone do. They want you to know that if a person has dilated ischemic cardiomyopathy, an implantable defibrillator will lower mortality as well. Why? Because you die of arrhythmias. They want you to know that beta blockers are absolutely one of the best drugs there is for congestive failure. It lowers mortality like you wouldn't believe because they're antiarrhythmic and anti-ischemic. They decrease consumption and increase supply. Isn't that wonderful? This is spiritually intact. Digoxin. Yeah, left ventricle, move, move, move. Digoxin. Digoxin mean to left ventricle. Beat, beat, So what would you do? Sudden death. ACE inhibitors, afterload reduction. Let me lighten your load. Relax. How would you feel if you had to carry less? And beta blockers? Why, beta blockers is going on a permanent 3-day work week instead of 5 days. Isn't it wonderful? How spiritually intact. How psychologically wonderful is that? Congestive failure. Take it easy, take it easy. Don't let the sound of your own ventricle make you crazy. ACE inhibitors, beta blockers, spironolactone, lower mortality.